Welcome back. Keith Stewart here from Toronto, from the Princess Margaret Cancer Centre, and I'm going to talk to you now about therapeutic approaches for the patient with relapsed multiple myeloma. I think it's worth reflecting before we talk about the newer data on the somewhat relative lack of efficacy of single agent or even single agent plus dexamethasone therapies in the relapsed myeloma population. We noticed even with thalidomide, but all the way through bortezomib, lenalidomide, carfilzomib, pomalidomide, and daratumumab, that single agent or single agent plus dexamethasone treatments are not that effective in this regimen or in this setting, with an overall response rate ranging from 25 to 60% only. And it's worth bearing that in mind as we go through some of the newer data. Some key numbers then I want you to remember as we start to look at triplets and quadruplet therapies are bortezomib dexamethasone median progression-free survival at first relapse is only 9 months. And for lenalidomide dexamethasone, it averages out around 17 months. So if we keep those in mind as we go through. I also want you to reflect on the fact that not all patients will make it to the next line of therapy. This is a study from England, which looked at the number of patients who completed their first line of therapy, and there was 1,800 of them. Those who completed their therapy and were in stable disease or remission, and those who had completed because there was a defined number of cycles pre-planned. The important point about this slide is that those patients who actually go on to complete the second line of therapy was only 61% of the starting population. Only 38% made it through the end of the third line therapy and only 15% through the fourth line. The point being that there's significant attrition with each relapse. And if you don't use your best drugs early on, you may never get to them, is the point of this slide. We are blessed in myeloma. When I started in myeloma, we had no randomized trials in relapsed patients, essentially, or very few. And we see now we've been blessed with not just with randomized phase 3 trials, but rather large trials exploring all kinds of different regimens, some of which we'll cover off on today. To go back in time a little bit, and the one doublet that probably does still deserve some close attention in the relapsed population was this the Endeavour trial where carfilzomib dexamethasone was compared to bortezomib dexamethasone. There was a doubling of median progression-free survival with carfilzomib. You will notice that for bortezomib, 9 months was the predicted, and the outcome indeed reflected that, of only 9 months for bortezomib alone. I think this slide, if no other slide, should convince you that bortezomib is not a drug of choice in relapsed patients if there is an alternative. Secondly, the ASPIRE clinical trial, which then took this one step further and looked at carfilzomib RD versus RD alone, should be familiar to you by now, again, showing a significant change in both median progression-free survival and for overall survival, particularly in those patients in first relapse, with a hazard ratio of 0.79 as shown here compared to lenalidomide dexamethasone alone. Now, some advances recently, the ARROW clinical trial asked the question whether twice-weekly carfilzomib could be made more convenient by switching to a once-weekly dosing regimen. A phase 1 trial suggested that 70 milligrams per meter squared could be tolerated and was effective. And so the experimental arm here was 20 milligrams per meter squared of carfilzomib week 1, 70 milligrams per meter squared in the ensuing 2 weeks. With a week off. The randomization was 1-to-1. There was 478 patients, 2 to 3 prior lines of therapy. So this is not first relapse, but rather a little bit later. They had to have a prior exposure to both IMiD and a PI. They had to have pretty good performance status, but they could have some degree of renal failure. This was set up, and in my mind, was really a trial to decide if this was equally efficacious and less toxic. We expected equivalence. But in actual fact, I think somewhat surprisingly and gratifyingly, it turned out that the once-weekly regimen, if anything, appeared slightly better than twice weekly, with a median progression-free survival of 11 versus 7.6 months, with a hazard ratio of 0.69. So that was a little bit unexpected, but nice to see. Also, overall response rates were higher with weekly dosing at 62% versus 40% for this doublet-based therapy, and depth of response was higher. One might think that this comes at the cost of more toxicity, but that turned out not really to be the case. If we look at, perhaps we just focus here on grade 3 or higher toxicities, you will see that really there is very little difference in the toxicity, and particularly notably, if anything, there was slightly more cardiac toxicity in the twice weekly group than in the once weekly dosing. I will say, however, that 70 milligrams per meter squared can be a high dose for many patients, and I would urge a little bit of caution. In my own practice, I tend to escalate up to that dose a little bit more slowly, so 20 in the first week and maybe going to 36 or 45, or sorry, 45 or 56 in the second week, and then eventually up to 70. I would also say that to be careful that you don't use 70 if you're going to use combination therapies. A lower dose is probably more appropriate there. Although we don't have a lot of trial evidence to support that conclusion, I think it's generally a safer strategy. Ixazomib has been used with lenalidomide dexamethasone as well. This is also the TOURMALINE study, which is should be familiar to you from published quite a few years ago now. It showed a rather modest but significant improvement in survival with progression-free survival with ixazomib versus placebo and lenalidomide dexamethasone. So again, an all-oral regimen, quite attractive. Again, we'll move to daratumumab, and I hope again that you've seen these studies before. The POLLUX study, which combined daratumumab with lenalidomide, and the CASTOR study, which combined daratumumab with bortezomib. We've shown them both on one slide here because they're very similar in design. This is the POLLUX study, probably the more impressive of the two. The 12-month progression-free survival was 83 versus 60%. The risk of progression or death, the hazard ratio was 0.37, so very significant. CASTOR, this is, again, we'll see that bortezomib here had a progression-free survival only 7 months in this study versus not reached for the daratumumab group, and again, clearly showing the advantages of adding daratumumab to this cocktail. Here we see that the MRD negativity rate for both studies, POLLUX with lenalidomide and CASTOR with bortezomib, and if you focus on the dark blue boxes, you will see at all levels of testing, and probably the only one we should really care about is 10 to minus 6. We see a doubling of CR MRD negativity rate, both for daratumumab with bortezomib or with lenalidomide. Another important therapeutic advance that just got FDA approval recently was the use of daratumumab subcutaneously compared to intravenous delivery, more convenient for patients, doesn't take chair time as much, as safe, and here we see as effective with the subcutaneous dosing showing an overall response rate of single agent drug of 41 versus 37%, so essentially identical, slightly higher, but really equivalent concentrations in the blood of daratumumab over time. So it seems quite highly likely that there will be a fairly broad switch to subcutaneous use of daratumumab quite soon. Elotuzumab, lest we forget, also showed activity in this patient population with, if we cut to the chase here, progression-free survival was improved when elotuzumab was added to lenalidomide dexamethasone with the progression hazard ratio of 0.54. Moving on to Pomalyst, many of our patients in the United States in particular have already been exposed to lenalidomide extensively or have been on lenalidomide maintenance when they progress. And one of the questions we often ask ourselves is, should we proceed with a regimen which doesn't contain an immune modulating drug, or should we use a more potent version of immune modulation, such as for today, pomalidomide, but in the future, iberdomide and other drugs. So here we see the results of the Optimism trial, which looks at bortezomib, dexamethasone again, versus the addition of those two drugs plus pomalidomide. Again, you'll see bortezomib performing quite poorly, 7 months alone, although these were slightly more heavily pretreated patients, versus the addition of pomalidomide improving by, again, about 4 months and hazard ratio of 0.6. So many of us have used pomalidomide now, even at first relapse, as our alternative to lenalidomide, as a more potent and as effective and perhaps less toxic alternative. So again, if we look at what the Mayo Clinic decided to do, and again, this is probably slightly out of date at this point, it's easiest to look here at the patients who are relapsing off of all treatment, so they're not refractory to lenalidomide. And we can see that here we had either daratumumab, lenalidomide, dexamethasone, or carfilzomib, lenalidomide, dexamethasone as our choices. We had maintained some usefulness for ixazomib and elotuzumab in the very frail patients. So I think if we were to redo this today, daratumumab would probably be our first choice over here, with the others reserved for later relapse. A little bit more complicated if you're actually progressing on lenalidomide. And I think the key elements here are to switch to pomalidomide or to use a regimen which doesn't contain an IMiD at all, as we'll talk about in a minute. Which brings us to isatuximab. So this is another anti-CD38 antibody, very similar in design and outcomes in early phase trials to daratumumab. This study was for registration purposes, more than 2 lines of prior therapy, had received both an IMiD and a proteasome inhibitor in the past, which in the US is everybody essentially, had progressed recently. Randomization was to pomalidomide dexamethasone as shown previously versus those 2 drugs plus isatuximab. Again, we see quite nice improvement in progression-free survival, 11.5 months versus 6 months. Again, these are 3rd or 4th relapse patients, so we wouldn't expect to see the higher numbers we've seen in some of the earlier trials, but certainly suggesting that isatuximab is effective, can be safely combined with pomalidomide, is a slightly more convenient schedule than intravenous daratumumab, and definitely an alternative to consider. The overall response rate was 60% versus 35%. Again, these are more heavily pretreated patients. MRD negativity was low in both groups, but there was some with the isatuximab combination. It's important to point out that perhaps the antibodies do interfere with complete response measurement, which may reflect the rather low CR rate that we see. I wanted to move to, I think, a very important and potentially practice-changing trial, which is the CANDOR study. And this looks at the issue of using an IMiD-free cocktail. So patients who are progressing on lenalidomide are maybe intolerant of the drugs, or perhaps have also progressed on pomalidomide. And it took the ENDEAVOR regimen of carfilzomib dexamethasone and compared that to carfilzomib and daratumumab. So rather than being the which one of the 2 should we use, carfilzomib or dara, it asked the question, perhaps both is better than one. You'll notice this is 1 to 3 prior regimens, so this is more comparable with the data from the CASTOR and POLLUX studies. Busy slides, so I'll just talk you through it, but if we start here with a response rate, and blue is the 2 drugs together, and yellow is carfilzomib alone, we see the overall response rate was better, VGPR rate and CR rate was better, and MRD negativity, here we see went from almost none to 12%, MRD negative when carfilzomib and daratumumab were combined. This translated into an improvement in progression-free survival. You'll see 16.9 months, sorry, that's the median follow-up. You'll see the not reached for the doublet of carfilzomib daratumumab versus 16 months, which is about what we would expect for carfilzomib dexamethasone, significant p-value and a hazard ratio of 0.63. So these drugs are highly effective when given together. What about the toxicity profile? Are we adding toxicity? Again, it's probably easiest to look at grade 3 toxicity. And you'll notice something very curious here, actually. Let's focus on cardiac failure for a second. So all grades with the two drugs together, 7.5 versus 10.5 for carfilzomib alone. Importantly, for grade 3 toxicity, 4% with the combination versus 8%. My interpretation of this is not that daratumumab is protecting patients, but rather side effects that are attributed to carfilzomib are in many cases actually attributes of the disease. And when the disease is better controlled by the two drugs, you see less attributable cardiac failure. You see a little bit less acute renal failure. And I think much of this is probably because the disease is better controlled and you're not seeing shortness of breath, ankle edema, and rising creatinines, suggesting we may have overestimated the toxicity of carfilzomib in the past. There is definitely, however, a downside to these two drugs together, and I want to talk about that now. The first is that respiratory infections are much more common, 73% versus 54, and 28 versus 15 of significant respiratory tract infection. Hypertension is a little bit higher. Fusion reactions are obviously higher because of the use of daratumumab. Viral infections also, and of course in the COVID era, we have to pay particular attention to this, 20% versus 14%. This translated then into more fatal events, 9.7% with the two drugs versus 5% with carfilzomib alone. And when we break this down, this actually turned out to be mostly due to infection. Carfilzomib and daratumumab are both highly effective drugs at killing plasma cells. Hypogammaglobulinemia becomes a big problem, requiring replacement often, and infection and death due to infection therefore becoming more common. So in summary, the two drugs can be given together with significantly longer progression-free survival. Overall, a 37% reduction in risk of progression or death. Deeper responses. The PFS benefit, I didn't show you that, but it was across all pre-specified subgroups. And actually, it was particularly notable in those patients who were refractory to lenalidomide. And the safety profile is, we've demonstrated to you, and we do have to be quite mindful of the increased risk of fatal infection using these drugs, even though overall at the end of the day, people had less risk of dying or less risk of progression or death than those who received carfilzomib alone. Moving on to some new drugs for a minute, venetoclax is making waves throughout hematologic malignancy. This was a very important trial, perhaps a little bit poorly conceived, but it compared bortezomib dexamethasone versus venetoclax. Bortezomib dexamethasone included all patients, not just those that we now recognize to be exquisitely sensitive to venetoclax, which are the translocation 11-14 population, making up 20% of your patients. And in case I forget to say it later, please remember to get T1114 testing done by FISH on your patients at relapse if you don't have it from diagnosis, because that's the only way you'll really know whether this drug is going to be highly effective. This describes the subgroup analysis of the trial, and I want to draw your attention to a few things. First of all, and what was disconcerting initially was the overall survival was actually worse or better for bortezomib dexamethasone alone than for the combination. Again, as you'll see, this is mostly due to an increased risk of infection in patients in whom the drugs are just not effective. However, for patients with translocation 11-14, the hazard ratio of benefit was 0.1. A tremendous improvement in progression-free survival for this 20% of myeloma population, which is why it's so important to test for it and try and access this drug if you can. Interestingly enough, another test that isn't clinically available yet, but is a companion diagnostic, those patients with high BCL2 expression also did very well. And as we get companion diagnostic testing, that will be another element where we might be able to identify patients who are not in the translocation 11-14 population, but do have high BCL2 who may still respond. So in summary, patients with translocation 11-14 or high BCL2 have very significant benefit with the use of venetoclax. Those patients who do not have that translocation or have low levels of BCL2 actually do worse, and they had a higher chance of dying. So these drugs should not be used in that population of patients. And with that, I will conclude, and I'll thank you for your attention.